We are diving into organophosphate poisoning. These chemicals, widely used as insecticides, pesticides, and nerve agents, enter the body through multiple routes and inhibit the vital acetylcholinesterase enzyme, causing a dangerous buildup of acetylcholine at the cholinergic synapses. So, remember, this accumulation triggers a severe crisis. Let us explore the mechanism of action of OPP. Under normal conditions, acetylcholinesterase breaks down acetylcholine to stop the nerve signal. Under organophosphate exposure, the OP chemical binds to and inhibits acetylcholinesterase. This blocks enzyme function, leading to a massive accumulation of acetylcholine and continuous, uncontrolled stimulation of postsynaptic cholinergic receptors. Sludge and dumbbells are the mnemonics you can use to easily remember the systemic side effects of these organophosphates. Muscarinic symptoms follow the sludge mnemonic: salivation, lacrimation, urination, defecation, gastrointestinal upset, emesis, bronchuria, bronchospasm, meiosis, and diaphoresis. On the other hand, nicotinic signs spell dumbbells, causing muscle weakness, paralysis, tachycardia, and hypertension, while central symptoms trigger anxiety, seizures, and respiratory depression. These chemicals can get into the body through various routes: ingestion, inhalation of fumes, dermal absorption through broken or intact skin, and direct injection. High-risk groups include agricultural workers, pesticide handlers, children, and cases of intentional self-harm. Therefore, recognizing these risks is key to prevention of OPP. Common typical chemical culprits include chlorpyrifos, paration, malathan, dichlorvos, dimethoate, and monocrotophos. Always remember, the final severity of a patient's clinical presentation depends on the exact chemical dose, the route of exposure, and total duration. Apart from the sludge and dumbbells we learned earlier, check out the other common clinical presentations. Mild to moderate signs present as headache, anxiety, blurred vision, abdominal cramps, and fasciculations. Severe poisoning leads to marked respiratory distress, severe bronchospasm, bradycardia, hypertension, seizures, coma, and respiratory failure. Remember this. 1. Pinpoint pupils, 2. Bronchuria, and 3. Muscle fasciculations are your classic clinical triad. When a patient is presented to the facility, laboratory investigations are conducted. We measure cholinesterase levels, specifically plasma pseudocholinesterase and red blood cell acetylcholinesterase. Order arterial blood gases to assess for hypoxia or acidosis, check electrolytes and blood glucose, run an ECG, and get a chest X-ray. In short, clinical judgment remains your primary diagnostic tool. Considering that OPP is an emergency, immediate management is needed. First, secure airway patency and suction secretions, assist breathing, and monitor circulation. For decontamination, perform gastric lavage within 1 hour of ingestion, administer activated charcoal, and wash skin thoroughly. Provide supportive therapies like bronchodilators, such as albuterol, and 4 fluids to manage shock. Specific antidotes should be given to the patient as follows. Atropine sulfate, which competitively blocks muscarinic receptors, is given to dry up secretions. 2 mg intravenous bolus for adults and 0.02 mg to 0.05 mg in children is the recommended dosage, followed by double doses in 5 to 10 minutes. Pralidoxime reactivates acetylcholinesterase, given at 1 to 2 g in adults and 20 to 50 mg per kilogram in children. For its effectiveness, it should be administered early. Benzodiazepines, such as diazepam or midazolam, treat seizures. Remember, atropine treats symptoms, while pralidoxime targets the root cause. Let's dive into the nursing management. Nurses perform rapid assessments, suction airway secretions, administer medications, and check SpO2 and ECG. Keep the head of the bed elevated to prevent aspiration. Also, provide skin care, emotional support, and pesticide safety education. In short, vigilant monitoring prevents critical decline. OPP, like any other emergency, has potential complications. These include respiratory failure, pulmonary edema, aspiration pneumonia, seizures, shock, and severe weakness. To prevent these, continuously monitor respiratory rate, SpO2, ECG, blood pressure, pupil size, lung sounds, mental status, urine output, and serial cholinesterase levels. In summary, remember sludge and dumbbells. Atropine is your primary first-line antidote, and early pralidoxime reactivates the enzyme. Airway protection and supportive care are life-saving. Early recognition reduces mortality. Recognize the signs, study the mechanism, and act fast.